Welcome everyone from around the world who's joining us. My name is Bill Cavanaugh and I am the director of the Center for World Catholicism and Intercultural Theology at DePaul University. We're a research center on the Catholic Church in the Global South, so Africa, Asia, Latin America, and running the behind the scenes efforts are Karen Kraft and Marlon Aguilar of the center. This talk that we're going to hear today on AIDS in Africa is part of a series that the center is doing throughout the current academic year on health, health kind of broadly construed. We just had an international conference online on healthcare and Catholicism in the Global South. And this was actually a topic that we had decided on before the pandemic hit. And then the pandemic hit and we put it all online. But it turns out it was somewhat providential in ways that we couldn't have anticipated. But we're very excited and pleased to have Father Jacquineau Azetsop join us today. Father Azetsop is a Jesuit from Cameroon, and he is the dean of the Pontifical Gregorian University School of Social Sciences in Rome, where he's joining us from today. His teaching and research there focus on issues of health policy, public health ethics, social dimensions of health, health systems, and the inclusion of the poor. He holds a master's degree in public health from Johns Hopkins University in the United States, and his PhD is in social ethics from Boston College, focused on issues of health inequality and social justice in West Africa. He has previously taught at the N'Djamena University School of Health Sciences in Chad, and at the School of Medicine at the Catholic University of Mozambique in Beira. And he is the editor of a book, HIV and AIDS in Africa, Christian Reflection, Public Health, Social Transformation, published in 2016, as well as many other publications. So please join me in welcoming Father Jacquineau Azetsop. He will give his talk and then we will have some time for question and answers afterwards. If you would, please, as you think of questions to ask, just put them in the Q&A function down at the bottom of the screen, and then I will get to as many questions as I can once Father Azetsop has gotten through his talk. So without further ado, then Father Jacquineau.
Thank you. So good morning, all of you, and I'm so happy to share the little I know with you. And I would like to thank the Center for Global Catholicism for inviting me to share this knowledge on AIDS with you and what the Church has done in Africa. I'm so happy to do it. So I just want to point out two things. You know, I work for many years at the National AIDS Council in N'Djamena in Chad as a health policy analyst. So some of the things that I will say is informed by my own experience. So it's not just books, but it's also a field experience, you know. So the talk of this evening is entitled HIV risk, social condition, and theological ethics. You know, I have learned from my previous experience that when I have to share what I know, I start by fleshing out my thesis and also the conclusion of my talk. So what is the thesis of this talk? You know, I argue that it is simplistic, you know, to appeal to individual rational choice to change risky behavior when people's options are constrained by social forces, which predispose them to certain behaviors and making HIV risk more a socially produced reality than a purely behavioral one. So what do I intend to say? I want to say that if you want to understand HIV infection and if you want to launch an HIV prevention program, we should not just look at or look into individual behavior or individuals' behavior, but also we should take into consideration contextual factors, social environment, how is society, the state of society. What is then the role of theological ethics in promoting, a program, launching HIV AIDS prevention program, which can actually address this double dimension, behavior and society? It will be to contribute. So the role of theological ethics is to contribute effectively to the prevention efforts, And so theological ethics must ask how large, scale social forces come to have their effects on unequally positioned individuals and countries. This is very loaded, unequally positioned individuals and countries, So it means that we should not just look into our country to understand how HIV spread. We should also think about transnational reason, transcontinental reason and structures, and we'll talk about that, How do human behavior and forces that obscure the visibility of the kingdom of God and undermine the dignity of people structure the risk for infection? This is a key question that theological ethicists has to know to address. In order to promote social justice and protect those who are most at risk, theological contribution to HIV prevention may question the predominance of behavioral and biomedical approaches over the social production approach. Theological reflection should provide epidemic research with an approach to personhood that accounts for the routes of exposure. We'll talk about that. It's quite complex, and is loaded. Theological contribution should search for adequate social theories to account for how individual pathologies are connected to social and even global trajectory, Theological contribution need to discern biosocial criteria for judging human behavior, Theological contribution should suggest the option for the poor as a way to promote public health through social transformation and structural interventions, And if you see properly, I'm not just talking about behavioral change, but I'm talking also about structural transformation, structural changes, And this is very much connected with Christian theology, social sin, structural intervention. A bit of methodology of this presentation. This presentation uses a historical, cultural, political economy approach to vulnerability that reflects, such an epistemological posture, orientation, reflects the comprehensive understanding of HIV risk in a marginalized continent like Africa. So I talked about behavior, I talked about social production, of HIV or of AIDS. Let's start with the behavioral approach. And we have this beautiful quotation from Loretta Koppelman, and in which, she talks about the punishment theory, which is an expression of a behavioral approach, which is a version of it. Let me share a bit of story with you. Some years ago, sometime in the early 90s, I went to a faith-based hospital for consultation. I was much, much younger. From nowhere, the general physician asked me, the one who consulted me, is it true that God punishes? Isn't it true that God punishes? He asked me. Don't you think that people living with AIDS or with HIV, with the virus, deserve what is happening to them? You know, that was in the early 90s. Are they not responsible of their own infection? You know, I did not know what to say. You know, what he said sounded a bit strange to me. But this physician simply appeared to be, to me, as someone who lacked compassion and who could not think beyond the stigmatizing representations that frame the moral underpinning of a disease which is directly or indirectly connected to sex. We all know, even today, stigma is a major enemy of HIV prevention, you know. So you're sick because you misbehave. You're sick because, you just deserve it because you did not do the right thing, you know. And sometimes the danger with some of the behavioral approach is that the causality is not factual, is moral, you know. Behavioral approaches are premised on individual ability to avert freely, to freely avert health damaging threats, you know. HIV infection is simply understood as an outcome, you know, of individual choices among many other options, you know. The ability to choose can be affected by providing sufficient incentive, you know, information, you know, legal arrangement, for instance. Determinants of population disease occurrence are understood as behavioral clusters and cultural factors that are shared among individuals, you know. So we can raise some question with regard to this approach that focus on behavior and the individual. What about a poor, uneducated, infected prostitute with few options, you know? We have tons of them in South Africa, for instance, tons in Zimbabwe. What about, HIV positive women whose faithfulness to an unfaithful husband cannot be doubted, you know? Should we say that these people are promiscuous or incapable of having control, personal control over their behavior? What about the social conditions and the social relationships within which infection occurs? What about, you know? So the interconnected explanatory idea named behavioral theory are based on biological, methodological, and moral individualism, you know. Just a big word to say that the unit of the anthropological unit for research is the individual, not the individual with his social connection, you know. Prevention is essentially viewed as a technocratic problem when we hold a behavioral approach to HIV prevention. You know, prevention is about, providing the right information so that the person can change his or her behavior. We have a clear example of such an approach that was called the ABC approach. As abstinence, so zip it up. Or be faithful, if you can be faithful, and if you cannot be faithful, at least use a condom, This was referred to as the ABC method. But is it consistent with what actually happened? ABC strategies fail to take into account the context of vulnerability created by social forces that shapes, for instance, women's life in most African countries. What about context? Where is the context? Where are social relationships? What does abstinence means, to women coerced into sex? You know, what does faithfulness mean when cultural politics deprive women of their own rights? You know, besides ethical religious considerations, call for condom use is meaningless in the context of gender inequality and feminization of poverty. You know, As we can see, the behavioral theory for disease etiology focuses on the individual human behavior. It erases the historical and contextual futures of disease process. History doesn't exist, you know. It erases biology, you know, and the process of embodiment. How come my behavior is embodied as a poor health outcome? Beyond the behavior, is there something else? It depoliticizes disease etiology. No, you know, there's no social policy involved. There's no gender policy lacking. There's no legal arrangement that can protect women and children, you know. In fact, my own pathology, my own HIV infection is the consequences of my own behavior. So the state has nothing to do. What the state can do is to provide me with information. Is that true? I think my own experience from my own experience, I will say no. So let's talk about the social production approach, you know. I will start it with a beautiful quotation of Bishop Kevin Dowling, the Bishop of Rutenburg Diocese in South Africa, talking about AIDS in his diocese, a diocese where there's a lot of shanty town, a diocese where you have a lot of people who congregate there to work to do mining job. I think we are facing an enormously difficult challenge. The brutalization of this society through apartheid and the hopelessness among so many youths who cannot get jobs, a deep lack of self-esteem, and just a fatalistic spirit makes people shrug their shoulders and say, I'm going to get it anyway. I'm going to get it. And therefore, I do whatever I want. I'm going to get it. Because life is tough. Whether I behave well or not, life is so difficult that I just can't live well, you know. This statement of Bishop Kevin Dowling affirms that, kind of point out that AIDS epidemic in South Africa is a social event. It's not just an individual event. It's not just an event solely related to the behavior of an individual. It's a social event whose spread is often propelled by the brutalization of society, a history of violence, political economy, and a culture of exclusion and fatalism. In opposition to the behavior theory, the social production theory conceptualizes determinants of disease distribution as economic and social relationships forged by social structures. Social groups defined by these relationships are differently helped or harmed by their position relative to each other, like wife and husband within the family, or poor and rich within society, or people living in the north or living in the south can have different level of exposure to a virus, to a pathogen. These relationships are conveyed in terms of social class, gender, race, ethnicity, social stratification, and position in society. So what is very important when it comes to, like the social production approach is that the focus is not on the individual as risk taker, but on social context, on contextual factors, and here I make a very clear difference between contextual factors and compositional factors. In public health, in epidemiology, this difference is very important. Individuals are understood, and this is definitely key, as being nested within a system of socioeconomic relationships that potentially influence individual choice. Choice is influenced, by the social position of the individuals. So HIV infection is mostly confined, as we see, sometimes even within a country or in a continent or in our globe, in the poorest areas. HIV remains the outcome of poverty and systemic violence, with sexual trade, migration patterns, polygamy, teenage marriages as predictor in sub-Saharan Africa especially. And I will explain when I will talk about the epidemic theory. This is very important. Let me just repeat this, please. HIV remains the outcome of poverty and systemic violence, with sexual trade, migration patterns, polygamy, teenage marriages understood as predictors, in the same line of thought, the line of thought of Kevin Dowling. Some of the top scholars, embrace the social production approach. For instance, Didier Fassin, a French medical anthropologist and a physician who wrote the best book on HIV in South Africa, clearly affirmed that the magnitude of the spread of the virus in South Africa is nothing else than the embodiment of the apartheid. He consigned his thought on the groundbreaking book entitled When Bodies Remember, Quand les corps se souviennent, when bodies remember. What do bodies remember? They remember the apartheid. How do they remember it? Through HIV. The body is located in society. The body appears in society just as a recorder, and the body records good events and bad events. Good events will uplift the body, but bad events will bring down, the integrity, the psychological, physical, and biological integrity of the body. Paul Farmer, we probably know it, an American medical anthropologist and physician who teaches at Harvard University School of Medicine and Public Health, wrote a famous book, The Pathologies of Power. He studied AIDS in Haiti and strongly affirmed that AIDS is nothing else than a pathology of power, because at the very root of the infection, there are issues of power inequality. So we see how society wounded by systemic racism, tribalism, deep-seated social inequities, gender inequality, political upheavals, negative cultural politics, and biased policy making processes breed wounded people. Wounded society, wounded people. So now we have a behavioral approach, which I criticize. We have a social production approach, which I embrace. With cautious, of course, with some caution, of course. And I can begin to think. We can begin to think differently. Maybe when we try to analyze, even epidemiologic data, or make sense of what medical anthropologists say about HIV/AIDS, we can begin to say at the very root of it, there's an anthropological question. How do we understand the human person in society? The question of personhood, Our anthropological claim on HIV prevention does not start with an atomistic view of human beings as distinct entities prior to or independent of human existence as communal. The idea of human beings conceived as free and rational entities are alien to most non-Western society. Cultures, if you go to my own place, you say, okay, I think, therefore I am. Well, people may laugh at you. Or if you go to my place, in fact, the witch is somebody who stands against the communal spirit, the poor person is not somebody who do not have money, but somebody who do not have good relationship, because when you're part of a good network, people will definitely support you, you know. So different understanding of the human person. I don't say one is good, another one is bad. I just say they're different, you know. So human beings are always caught up in a web of social intercourse that makes them either or both strong or and vulnerable. This is very important, you know. We often talk about social capital, you know, Bourdieu, Robert Putnam or Coleman. We talk about social capital, you know, which is very important for health, you know. You know, there's a lot of research on that, you know, but we can have a bad social capital. You know, if I'm part of a gang of thieves, that's a very bad capital, social capital. But if I'm part of people who can, you know, like, who do something out of their life, you know, for the betterment of society, that means I'm with good people and therefore I can flourish. So the anthropological question for me is not a peripheral question, you know, it's the heart of the matter. Because the anthropological vision that we uphold determines epidemiologic theory, determines ethical judgment, determines social policy, and even society intervention. How the society intervention to intervene, you know, like in the midst of, you know, public health chaos. The way I understand the human person and society can determine how society is going to intervene. An approach to human beings and society, which are shaped by liberal or communitarian ideas, will provide HIV prevention with a given ethics, you know, a given epidemic theory, a given policy orientation. So let's talk about epidemic theory. This is definitely important also, you know. Just as our approach to personhood, our epidemic theory need to provide us with connection between human behavior, you know, history, social structures, and individual pathologies, you know. We want a complex theory. To understand an epidemic, you know, a one-sided theory will not help us. The fundamental causes, that's one of the theories that I want to share with you, of infection refer to contextual factors that shape HIV risk. Social conditions are linked to a very broad array of diseases. This theory was developed by Phelan and Link. These two people teach at the Mailman School of Public Health at Columbia University, you know. Social factors influence different processes by creating vulnerability and susceptibility to health risk in general, rather than any specific disorder. These structural causes are steady. They include access to basic resources that can be used to reduce exposure to HIV virus and avoid negative outcomes. Social conditions are likely to be fundamental conditions of HIV infection because they embody access to important resources, affecting multiple disease outcomes through multiple mechanisms. Poverty and violence are the fundamental causes that determine myriad of predictors. As a result of a socially entrenched violence, systemic, I don't know if this is correct English, entertained poverty, AIDS, as Paul Farmer once said, is a pathology of power. Systemic violence is far from being accidental. Rather, it is intimately connected to social conditions that often determine who will suffer abuse or who will be shielded from harm. The social dimension of HIV infection and of AIDS production demands that the research apprehends how the embodiment of inequality occurs. So we have one way of understanding it through the theory of the fundamental causes, you know, and the fundamental causes is the cause of the causes, the cause that determine other causes. And other causes are often what is called mediatory factors, and we'll talk about it. But we cannot just look into a given society. We can look into regions within a continent. We can look in an entire continent. We can look beyond a continent. You know, we have systemic tales of HIV infection in Africa. Just like when Paul Farmer studied AIDS in Haiti, he flesh out systemic tales, you know, transnational tales of HIV in Haiti. And here we can use a theory with all its limitations, you know, we have to be humble. The world system theory allows us to capture the transnational nature of vulnerability. In most African countries, historically deep and geographically broad connections come into play with very little effort. The epidemic is, in part, an outcome of globalization defined as imbalances of power privileging industrial nations. Many experts blame the impact of structural adjustment programs on the spread of HIV in Africa and even on COVID. You have a big literature and neoliberalism in COVID, not in Africa, but in Europe, in North America, you know, not in Africa, you know. Structural adjustment programs that were initiated by the International Monetary Fund and the World Bank contributed to increase the intensity and the extent of poverty within African countries. These neoliberal reforms led to shrinking incomes while at the same time the introduction of user fee within the hospital system into the provision of health services meant that the poor were not able to access medical care. Structural adjustment programs exacerbated women HIV risk. Poor women suffer greater economic vulnerability under this policy, which depressed income among the lowest socioeconomic sectors, feminizing the epidemics. There's a very radical book written by some scholars, you know, all over the world, entitled Beyond Epidemiology. At the conclusion of that book is the World Bank and the IMF should apologize for implementing structural adjustment programs in Africa in the 80s and in the 90s, you know, because the continent reached the peak of HIV infection at the very moment that these programs were being implemented, you know. So in the book Beyond Epidemiology is a radical book, you know, radical book. So the theory of the fundamental causes, you know, the cause of causes. The fundamental causes is poverty and social systemic violence, okay? But infection has a transnational tail, which is connected to the strength of capitalism, expressed in its form of neoliberalism. That's what I'm trying to say. So we can then understand the process of embodiment. How do I embody a wounded social environment as poor health outcome? You know, how does society enter into my body? That's what Bourdieu said. Pierre Bourdieu once said, embodiment is the entry of society within my body, in my body, under my skin. You know, society get under my skin. Embodiment of social conditions occur through mediatory factors such as teenage marriage, sexual trait, migration patterns, polygamy, cultural politics, political upheavals, and neoliberal exploitation. And here, the last part of it, and I can even say colonization. You go to the southern part of Africa. I wrote a paper with a scholar from Malawi, and we study, you know, the case of HIV, the spread of HIV in Malawi. And we see how it's very much connected to migration patterns that was designed during the colonial period, whereby center of productions are located in given parts of Southern Africa, and workers congregate to those places. And those places are places where infection, the disease mushroom, like the spread of disease is just, like the magnitude of infection is very high in those areas. And these men who work in these farms carry the disease back home. And that's why the situation, the HIV, the HIV infection situation in the southern part of the continent was terrible, you know. So poverty, supported by violent institutions, social institutions, and neoliberal capitalism, is the fundamental cause and is embodied via mediatory factors. And the mediatory factors are the factors that we flesh out: teenage marriage, sexual trade, migration patterns, polygamy, cultural politics, political upheavals, neoliberal exploitation, and even colonial patterns of business patterns, which still exist in Southern Africa and in the entire continent of Africa. We talked about, disease production. We talked about epidemic theory, which is a very complex thing, and we put together, the fundamental causes with the transnational nature of infection, transnational tail of infection, and we flesh out, the process of embodiment. So what about moral judgment, Mm. We talked about the behavioral approach to infection. We talked about the social production approach to infection. How do we make judgment when it comes to assigning responsibility, HIV infection happens through social contact. Behavior and a certain level of moral cooperation is involved. Ultimately, something has to be sexual. Okay, we have transfusion, we have other means, but most of the infection are connected to sex, for sure, So that means that people should be challenged to uphold high moral standard. No doubt about that. I don't intend to undermine human agency. I don't intend to, to blame society about all of it. There's a part which is connected to what the individual should do. However, moral judgment about infection cannot be one-sidedly blamed on people's behavior. The validity of a moral judgment requires a clear understanding of agency, causality, responsibility, and routes of exposure. Let's talk about agency. It is not always evident that cognitive exercises would alter risk for poor behavior. We have all sorts of cognitive theory out there in social psychology and even in public health, and social work, many sciences, in nursing and so on. Cognitive rational pole, the cognitive rational pole of prevention may be overemphasized, the cognitive rational pole of prevention may overemphasize human agency, in turns minimize the fundamental cause, that is the structural pole. So we can ask too much of an individual, you know, an individual who has a few options, we can ask way than the person can give, Risk for infection does not merely depend on the knowledge of HIV transmission, but rather on one freedom to make choices, just like AIDS management, you know. To alter individual behavior in a sustained and effective way, we need to address social practices, community norms, institutional arrangement, even legal arrangement, in some countries, you know, it's still written on the is written on the constitution that men should, you know, discipline, or a husband should discipline their wives. A husband should discipline his wife, you know, which is something that I don't accept, you know. We need to address legal arrangement. We need to talk about, you know, what is the anthropology or the type of society that we want to build when we have this type of laws. Causality. Establishing a direct causality between behavior and HIV infection, or between cultural practices and beliefs and HIV risk, is simply immodest and misleading, you know, because these claims of causality ignore how inequality, poverty, and violence play out in individual pathology. Behavior is the proximate causal factor, while the whole array of factors must be considered in order to identify mediatory causes, which are themselves fueled by poverty and violence. Behaviors are not determined by by one single factor, but by an array of elements which in combination structure this behavior. This is complex. It relates to what I say about epidemic theory. Mediatory causes of mediatory causes are particular mechanisms through which distal causal factor, poverty and violence, shape the risk of infection. Mediatory causes which change over time will change over time, while the influence on fundamental cause will persist. So addressing these mediatory causes will do little in the long run to eliminate disease and promote health. This is very important. You know, we say mediatory causes are migration pattern, early marriage, you know, some of the stuff that we know. We can change that, you know. You may find people who send their daughter to marriage, you know, just because they're poor, you know, they want to get money, you know. Or you may find that somebody will migrate to a remote area to work just because he needs money. Where he lives, he has few options. First, he's uneducated. He doesn't have any opportunity. The government is crappy. There's too much corruption. You know, we may change those mediatory factors, but if we don't change the bedrock on which these mediatory factors are anchored to produce poor disease outcome, in the long run, we may have another epidemic. So this is what I'm trying to say when I talk about causality. You know, unless poverty and violence are addressed more consistently, there will be very little progress in reducing AIDS epidemics and preventing future epidemics. The epidemic is still going on, you know. To avoid taking responsibility for the social origin of poor health, a cognitive cultural explanation can be overemphasized at the expenses of a structural one. Let's talk about responsibility, therefore. The fact that the behavioral approach failed to explain risk and infection rate differentials, failed to explain differences in HIV prevalence from one country to another, from one place to another within the same country, from one continent to another, and across the globe, strongly suggest the need for inquiring into the contextual factors, the social environment. With Lisa Cahill, who once taught me, I reject a sex-focused approach for assigning responsibility for the infection. Instead, AIDS is a justice issue, not primarily a sex issue. As a justice issue, it concerns social relationships, social and structural relationships that help spread HIV and fail to alleviate AIDS. Relationship of power, relationships of vulnerability that are in violation with Christian norms. Focus should be essentially a bit of modesty, move from the individual to social forces and institutions that constrain human agency. You know, I still remember what Louis Pasteur, the father of microbiology, once said, that the pathogen is nothing. The terrain, you know, the field, society is everything, you know. So how do we respond to, you know, an epidemic which is, well, connected somehow to sex, that has a certain level of involvement of human behavior, but which is deeply rooted in the social fabric? Or the option for the poor, you know, and structural intervention. This option is shaped by the transcendence of a God who takes side for the marginalized and by the liberating praxis of Jesus of Nazareth. The solidaristic love of God for his people is totally fulfilled through Jesus' life and death, which opened a venue for an hermeneutics mediation, allowing us to understand the life of the destitute sick. Effective solidarity for HIV prevention cannot focus solely on behavior change in isolation from social structures and institutions that create risk environment. The incarnation of the Word of God, Jesus' ministry and his earthly life have an important theological and moral significance for the option for the poor. And these two events play a normative and inspirational function in shaping structural interventions. Structural interventions are consistent with the social justice tradition of the churches and with the principles of the Ottawa Charter for Health Promotion. When I talk about structural interventions, what do I mean? Which are interventions that means to change the social, the political, the legal, the cultural environment in order to promote people's well-being. The persistence of oppressive structures, both at the level of the family, national, and global levels, reveals the sin of the world that contradict the kingdom of justice and peace inaugurated by our Lord Jesus, by the man of Nazareth. So let's conclude now. I don't know if you're convinced by what I'm saying. I'm not here to convince you, just to share the little I know. And I know that, I mean, this is not the word of God. What should theological ethics do, finally? Theological ethics need to disentangle the ideologies that shape the dominant view of prevention by placing human dignity and respect for an entire continent at the center of epidemic research and theory. If you remember more clearly, when HIV started spreading, there was a creation of new identities, a sort of new alterity that leads to exclusion and stigmatization in terms of the we and the they culture, the we and the they logic, you know. Immodest claim of causality between infection and culture, infection and race were issued, words like, oh, the culture is so messed up, the people of this color and so, you know, reproduction of colonial and racist representations, when was quite popular, and even using individualism as an adequate framework for global health, for AIDS prevention, was also very much present in the way things were done in the early age of AIDS. We have gone a bit beyond that, but not totally, you know. Secondly, theological ethics need to promote social justice through structural changes and collaborative action with other social constituencies. So it needs to evaluate what has been done to come up with an action theory and a reality-based social activism. There's a need to strengthen ecumenical, interreligious, social dialogue on important social issues to favor advocacy initiatives. The need to theorize and advocate for a normative and transformative activism based on Christian values. The need to launch research to understand the peculiar contribution of small Christian communities, especially, in many parts of Africa, in many villages, in popular neighborhoods. The contribution of home-based care that was born from Christian values, especially by women association, the contribution of parishes, of Christian National Health Council, especially in Southern Africa, in places like Nigeria and Ghana, in dioceses, in national episcopal conferences to fight the pandemic. So what is the specificity of these, small bodies, that work out their way, to prevent the pandemic? Also, we need to study more deeply how structural intervention launched by the churches have been helpful. You know. Finally, theological ethics need to engage macrosocial policy, and call for intersectoral intervention as proper initiatives, and therefore having association of, Christian physician, Christian, I don't know, pharmacists, Christian lobbyists, Christian policymakers who can speak to other constituencies to lobby for proper policy is definitely important. Beyond single issues of condom use or access to healthcare, for a given disease, it's good to address broader social challenges that may reduce vulnerability to pathogens, For example, arguing for universal access to care instead of access to AIDS care, eh? Improving girls' access to school to reduce the number of women that we can find on the street doing prostitution is definitely key. Changing transport policy to prevent transmission by drivers along highways. I worked in Chad for 7 years and I was a member of the National AIDS Council. And we launched some studies and we saw things unacceptable. Places where the rate of infection was 10 times higher than the national average. Mm? So, conclusion, and I'm done. So, after many years fighting HIV, you know, we have learned a lot, as churches, Christian churches are men and women of goodwill to not accept narrow-minded, one-sided, and untested pronouncement in times of epidemics. We can say the same for the COVID-19. I just issued a paper entitled COVID-19, the coloniality, economic colonialities and justice in Africa. Many things can be said, things can be said. We need to avoid ideas and theories which have been shown to be limited and have been proven wrong. We need to borrow, especially in time of epidemics, from social epidemiology. Epidemiology which is shaped by contextualizing sciences. We need to borrow from contextualizing sciences to account for how history, cultural politics, political economy, and socioeconomic exclusion determine behavior options and contribute to infection. We need to provide a theologically sound anthropology for epidemic, for disease prevention, disease management, and the spread of pathogens. And finally, we need to develop a sound social ethics within which personal ethics should be connected. I strongly believe that the ethics of AIDS should not be first understood as a personal ethics, but it should be primarily a social ethics. If the matrix of society is well shaped, will reduce the likelihood of behaving poorly, you know. And even when it comes to bioethics, I'm one of the people who strongly believe that bioethics should be primarily a social ethics. Even when the patient and the physician are talking to each other in that small consultation room, society is with them. The laws that they have to follow are shaped by society, determined by society. So I don't know if, I mean, this is the little I have prepared. So I'm open to question, of which I will not have all the answers, is about sharing. So thank you.
Well, thanks very much, Father Jacquineau. That was a really interesting and provocative and thorough account of why we need to look at structural issues and not just behavioral issues. So we have questions in the Q&A. I think this is going to elicit a lot of response. We have a lot of questions already. If you have questions, please put them in the Q&A and I'll get to as many as we possibly can in the next 20 minutes or so. So the first question comes from Ed Young, and he is asking, saying these insights from the experience of HIV/AIDS in Africa would have saved perhaps many lives in the LGBTQ community in the United States. And he's asking, how accepted in sub-Saharan Africa are the social economic constructs approach versus the individual responsibility approach? So are you a voice in the wilderness, in other words, in advocating for this approach? Who promotes the behavioral approach? Is it the church, the state, the NGOs, and who promotes the structural change approach?
Yeah, it is quite complicated, quite complicated. The church has done a lot. The church has done a lot in, like in addressing some of the structural issues, one of the key ways of, of helping people, is, for instance, through income generating activities. Many women have benefited from that, and also skill training, those are forms of structural intervention. You change the economic environment of the person to improve his ability to enact good behavior, So the church has done it, many NGOs have done it, and also there's a bit of politics. Let me share an experience with you. I was part of a team of public health trained people who carry out a research on mother to child transmission. We did it in 2 regions of Chad. In one region, we conditioned prenatal care to HIV/AIDS testing. Compulsory, was compulsory. In another region, HIV/AIDS testing prior to prenatal consultation was optional. A proper counseling will be given, and women will be allowed to be tested or not. So when we launched the story, we realized that transmission in the region where HIV/AIDS testing was compulsory, was less than 1%. That means 99 women will protect the newborn baby, even when they're infected. In the region where the test was optional, the rate of, infection was more than 15%. That means 85% of women, 85 women will be able, over 100 will be able to protect their kids from having HIV when they're infected. We went to the government, to the Ministry of Health. We have rocket science, we have field research. You have to design policy. Why don't we condition access to prenatal care to HIV testing? But you know what? Election were near. elections were near, and the government did not, design policy on prenatal care. You see how a new legal arrangement on the access to prenatal care could have saved many lives, but the decision was not made. That's just a macro, let's say, another aspect of the issue. But when it comes to structural intervention, at the moment, people have understood it, but sometimes the government does just do it. So.
Okay, great. Well, that kind of leads us to the next question from Rick Bauer coming from Kenya. And he's saying, I'm going to summarize the gist of his question, but he's saying, look, he agrees that the structural issues need to be addressed, but also there are issues that can be addressed right now to save lives. And so he says, if implemented, they can eliminate AIDS by 2030. First, we have to ensure that every HIV positive person has access to testing, treatment, and support. Second, have to ensure that every pregnant woman has access to prenatal services, just as you were saying. And so implementing these interventions can save lives today while simultaneously working on some of the broader issues. So how would you respond to that?
I totally agree. I totally agree. And there's one word, universal access. Is there a way we can ensure that every single citizen can have access to basic care? We know when the disease is catch on early on, the person can survive longer. If prevention is done early on, we can avert infection. So what I will insist on, universal access to care. That's definitely the way to go. I remember somebody wrote an article, okay, saying we have fought for an AIDS-free society. Perfect. We cannot polarize all our efforts on AIDS. Now, let us focus on providing our people with access to care, because that's the major solution to the HIV pandemic and other pandemics that we may face in the future. People need to have access to basic care, and government need to make provision for that. So I totally agree. I don't know if I should add something.
Okay, great. Thank you. So Nikita L is saying she appreciates your presentation. It gets.
Oh, I know her. Oh my God.
Okay.
Oh my God. After many years.
He says,
17 years, Nikita. Wow.
So she says that one might get the impression that HIV/AIDS has been eliminated just because you never hear about it in the news anymore. The news is all about COVID, and she's wondering if in the midst of COVID, there are still public outreach movements as there were previously with regard to AIDS.
Yeah, excitement about AIDS has gone down tremendously. But, the gain that we have had with regard to what happened before, have been maintained in terms of the way provision to care is structured. Some of the solutions that was designed in healthcare centers, in, like hospital, district hospital, or high research hospital have been maintained. But funds have dried out. We don't have as much money as we used to have, so there's a bit of, fatigue, but the disease is still going on. People are still infected, it's not yet over, but the problem is, according to me, is, like one of the points that I mentioned at the end, did we sit now, think about what happened, and the solution that we designed to, to respond to the crisis? How can we capitalize on that? How can we build on that? How can we make it, like take it as a lasting gain? We need reflection, but we also need to anchor it into the way we actually run healthcare institutions, and how we actually, public values that help us to address some of the major health challenges. This is definitely key. What are the gains that we got from what went on some years ago? So how can we make it a lasting gain, a gain that lasts forever, So definitely important. And to talk about COVID, let's just say one word about COVID. I'm so excited about it, And I mentioned neoliberalism, I was amazed that richer countries which are highly rich, on the onset of the disease, sorry, did not have enough mass to face, to protect medical personnel and even to protect people. I talked about COVID, HIV, and neoliberalism. How we have disempowered the government. The government should not intervene in social affairs. This is one of the major credo of neoliberalism. We all know zero state intervention, And now we're going back on what I may call state capitalism, The head of state will actually decide, just like here in Italy, Jacquineau, you will stay in your house, you're not going out. You're not going out because we need to protect you. So we're going back to government deciding everything for us, Deeply down, we have to, to think more critically. The model of society that places finances or finance before the social has failed. We cannot take it anymore, Just like HIV, we reached the peak of HIV when structural adjustment programs were being implemented. We cannot deny that. This is factual. History has recorded it, So the neoliberal vision of society is a failure, according to me. I'm very strong on that. I'm sorry. If somebody is against me, I'll take it. It's a failure. A society that places finance before the social, is not acceptable.
Okay, good. Well, the next question I was going to ask, but I think you've already answered it, is what lessons can we learn from HIV and AIDS for COVID? And I think you've already addressed that. So unless you have more to say about that, I'm going to move on to another question. Actually, I'm going to combine a couple different questions because they're both about the church. Dr. Vincent Manning asks, you've talked about the body of Christ, but the churches can remain highly stigmatizing social environments. What structural factors within the church increase vulnerability? How might Christians be more involved for change within the church? And then there's a similar sort of question, though different, from Mexico. Our experience in Mexico is ignorance worsens the HIV epidemic. So what is the role of the Catholic Church in sex education in elementary school? So if you...
I mean, like part of our anthropology should be we are sexual beings, we are sexual beings, and we should educate people that way, And I may acknowledge that in the church, sometimes when things are connected to sex, we tend to keep silence, We can see the whole issue of sexual scandal within the Catholic Church, We were a silent church, a church that will not talk about sex, and the church that will protect itself, having a wrong image of who we are, yet we are a church of sinners. We have to acknowledge that we are sinners and that we need God's mercy. And, I remember reading an article from, what's her name again? A nuns who taught at Yale University. What's her name?
Margaret Farley.
Margaret Farley, thank you so much. She talked about the grace of self-doubt. Can we doubt about ourselves? And the lack of this critical introspection made in such a way that we have a wrong image of who we are, a highly hierarchical church with people who misbehave because they are the high-ranking members of the church. So, we could not question their behavior. So we need to acknowledge our anthropology should also have this important future that we people are sexual beings, and that sex can be used positively or negatively. This is possible. But also, most often what I've seen in the church, when something is connected to sex, we don't want to talk about it. We tend to refrain. But as I see what happened in Africa, there was a slowly, there was a progress towards beginning to talk about sex. I remember working at the National AIDS Council in Chad. We'll go and have what we call sociocultural talk in villages. Sometimes the parish priest will lead us into the process because he's an influential person in that village. Let's have sex talk. Let's talk about sex, and we talk about how sex can be good and bad. What are the right places of having sex in the time of pandemic? What we should not be what we should not be doing. Actually educate people within their own culture. We did it in Chad, and we save a lot of lives doing that, because cultural debates and social talk. I don't know if I'm answering. You have other responses. I'm just trying to talk.
Okay, great. So another question, another church-related question from Telesia. As we shun behavioral theory that's focused on the individual, I'm curious to know how you would negotiate religiosity and spirituality as you advocate for transformative activism based on Christian values. So how does, if we kind of move from the personal to the political, the larger scale, how does your Christian faith inform that?
Yeah, but I will say religion is political, no, and even spirituality is political, is the way I express, my own belief, is the way I live my faith, as a person and with other people, and the whole issue of being Christian in the public sphere, which is quite complex, but at the same time is about, like meeting other people and talking to them, building consensus on issues, and negotiating around the complexities of human existence and human life. I know it's not easy when we meet people who do not share the same faith like us, but at the same time, we are human beings, we can build common goals, and do things together. We cannot, what I've seen there were, I mean, like even with people working in NGOs or people working sometimes at the level of the UN, tendency to exclude faith-based institutions. And all of a sudden, a huge return, massive return to faith-based institutions. We witness it. Among the participants of this talk, we have Father Elfesh Kenom, who was the head of African Jesuit AIDS Network. We work on it together, African Jesuit AIDS Network in Nairobi. There was a certain time faith-based institutions were excluded, and all of a sudden, a radical return to us. Why? Because we have something to offer that other people do not offer. The question that you raise is quite complex, it's about dialoguing, it's about expressing what I believe. I remember as a priest, we were 3 Jesuits, we went to the AIDS Society of Africa. We went to the annual meeting of the AIDS Society of Africa in Addis Ababa. I was not courageous enough to wear the Roman collar. It's not really my type. I don't often do it. But the other Jesuits wear a Roman collar. They were courageous, more courageous than me, and they were stigmatized. Yet we're doing a great job for the entire continent. from Nairobi and spreading our efforts all over the continent. We did it together, but how do I account for my faith is definitely important. I should account for my faith not in a conflictual way, but in a constructive way, the way I approach others and the way I convey what I believe in makes a difference. That's what I will say. But we cannot refrain from saying that we are men and women of faith. This is definitely important. Yeah.
Okay, thanks. A couple more questions here, and then we'll wrap up. Question from Josie Garnham. What are the best practices for bringing, so what are the main causes for people who drop out of care, and what are the best practices for bringing them back?
Yeah, I mean, probably a physician among us may respond to that question. But in the early on in the AIDS infection, people may refrain from seeking care because of stigmatization. They're stigmatized, and sometimes even people passing near an AIDS care center will look, like negatively. The way they will talk to people who are HIV infected will be, very negative. They will talk down to people instead of, having compassion and saying, okay, these are still human beings. So stigma is definitely important, and especially in the early age of AIDS, people who were infected were afraid to be seen as people who were infected. But slowly and slowly, things change. In the book we edited from African Jesuit AIDS Network in Nairobi, there's a chapter written by a Dominican from South Africa he is an historian. He documented the change of attitude with time among Christian communities in Southern Africa. And the climax of this change is the creation of home-based care. Is a clear acknowledgement that AIDS is with us. AIDS is in the church. And now we have to support our people, So there was a radical change of attitude. Even today, it's not like it was before. So stigma is the major enemy of HIV prevention.
Okay, there's just one last question from Ed Young, who began our questioning. He asks, in Ghana, there are many evangelical fundamentalist Christian communities. Do you find a resistance among these communities that try to hold on to the individual responsibility approach?
Yeah, we have them. We have some Christian groups who are, I will say, they have the spirituality rooted in a moral analysis of infection, which is very stigmatizing. So what can we do? We need to educate them. We need to educate them. And I don't know, we have all types of theories that lead to the change of people's perception. Is it going to work? When negative perception or stigmatizing perception are rooted in religion, sometimes it's very difficult. It's very difficult, But one of the things that help many people, even within the church, is when one family member is infected or one relative is infected, we change the perspective. And people have changed the perspective because HIV was in the house, was in the family or in the neighborhoods. And they begin to develop a different discourse, because, having somebody that they love who is infected and affected, change their own perception. The discourse be change into something different. So that's much I can say.
Well, thank you so much, Father Jacquineau. You've really given us a sense that when a problem is as big as the problem of HIV/AIDS in Africa. We need to think big as well and think about structural solutions and not simply band-aids. And I think there's a lot to learn about the current pandemic in that wisdom as well. You've drawn on the Christian tradition to help us navigate those issues. So thank you everyone for joining us from around the world, and please join me in a virtual applause for Father Jacquineau. Thank you so much. Please check out our events on our website as well, and thanks for joining us.